Good morning, everybody. I want to thank Professor Richard Cash, who's a very famous professor from Harvard School, who has done a lot of work on epidemiology. But more important is he's done a lot of work in low-income countries, and especially in Bangladesh. He's also been teaching in India and Kerala, especially with Shebika, so he has a good understanding of where he comes from. So it's really an honor for us in IPH to have him here. And before we start, maybe we can just do a quick round of introduction. Your name and where you're from, what are you doing?
I'm Shebika. I'm working in the Untitled project. The project which we're doing is in Bangalore and also including the project.
What is your background?
I'm a trained medical doctor in public health now.
I am Untitled. I am also working in Untitled project. I am from Master of Social Work background.
My name is Tanya and I'm also a faculty at IPH. I'm a medical doctor trained in community medicine.
I'm done my PhD and I'm working in health. Where did you do your PhD? Yale University, Bangalore. I'm already married. I'm working in the health project and economics.
I work in the e-learning and IT related activities. So of course, yeah.
My name is Mariah. I'm a university from Massachusetts.
I'm the used to be part of IPH, part of Society for
It's very nice.
I'm an management graduate and in the project. This is an actual research on strengthening the health system.
Okay, very good. Well, I'm going to, how much time do I have?
Till 1 o'clock.
Till 1 o'clock. Ooh. So I'm going to talk about the issue of scaling up health programs. How do you take a demonstration project and expand on it? And I'm going to give you, the work that I'm going to talk about is basically from an NGO that I've worked with for many, many years called BRAC-A, which, as you will see, is the far and away the largest NGO in the world in terms of people and so on. They have well over 100,000 employees. So it's not just health, it's a development organization. But I think that they have done extremely good work, especially in the area of development and scaling up. The founder of the organization is Sir Fazli Abed, and he's fond of saying small is beautiful, but big is necessary. So that and I'm going to demonstrate this with 2 health projects, one of them on DOTS, directly observed therapy for TB, and another, a much older project that is since finished on oral therapy, oral rehydration therapy. And then I'm going to posit or suggest that some of the methodology that has been developed could well be used for other interventions, especially for HIV/AIDS. Okay? So that's the sort of agenda here. There is a book, by the way, called From One to Many. I'm a senior editor on it. I can try to maybe send you copies of it sometime. They're all published in Bangladesh, and it's based on a conference that was held about 3.5 years ago on this very topic, on scaling up health programs. So the lessons from their particular, you can all hear me, right? I don't need to use the microphone. Okay. So the lessons are as follows. One, that scaling up is multidimensional and multidisciplinary. Secondly, that you need to commit to scaling up from the beginning of a project. It's not an afterthought, it's a before thought, okay? And that you must have an institutional vision as to what you're trying to do. In this case, their vision, the vision of BRAC, is to alleviate poverty, to create equity, and to particularly empower women. So that this is their underlying ethic of who they are. That pilot programs are needed with relevant research and evaluation, and you need to train your workers prior to scaling up. You can't say, well, okay, we're going to expand our market, but then you don't have any outlets or people trained to do this. Businesses know this quite well. Management needs to be appropriate and down to earth with very strong supervision. None of these programs can go through unless you have people being supervised at all levels within the system. And it's not, and when I say supervise, I mean twice a week, once a week, not sort of once every 6 months, okay? And you need to evaluate, adapt, and advocate, and you need to be realistic about your time frames. What I'm going to show you in their BRAC-DOTS program was accomplished over about a 15-year period. It's not something that you can do and then roll out right away. It doesn't quite work that way. So, a brief history of BRAC is it began in 1972 in post-war Bangladesh and is now the world's largest NGO in terms of workforce, certainly. The mission is to work with poor people to bring about positive changes in the quality of life through a holistic approach. So health is but one of the many activities. Their platform is usually one of microfinance. And then things are built upon that. It's pro-poor with a focus on empowering women. They are in it's probably 65,000 villages with an expenditure, I'm sure I'm off on this, of about $540 million. We got space here at the table, please. $540 million, of which they generate around 80% of their own budget through businesses and other activities. It's international and it's now in 12 countries. So just to give you a sense of the organization itself. So I'm going to talk about their community-based TB control program. A book came out on this about 1.5 years ago called Making TB History, and I will try to bundle these things together and send it down to you so that you have this. What is the DOTS TB strategy? There are 5 components. DOTS stands for Directly Observed Therapy Short Course. Directly Observed Therapy Short Course for the treatment of tuberculosis. This is the WHO approach. And there is government commitment, case finding, whoops, did I touch something?
No, current is good. Yeah.
I am computer challenged, so I will depend upon your good skills to maintain the system here. So it's you need not see most of the PowerPoints anyway. It's government commitment. You need to do case finding and diagnosis, short course chemotherapy for 6 months, which is long but short based on what it was, and then a supply system and recording and reporting. So you've got to have the government's got to commit to itself. You've got to find the cases, treat them properly, make sure you have a good supply system, recording and reporting. Okay, there we are. Now, their program began in '84 to '89 in a sub-district which is about the size of a tulip, you said to me, about 220,000, with Shasta Shebika. The Shasta Shebika is a volunteer in the community, although the term volunteer is, I would say, loosely used because she generate income based on a number of different parameters. In TB, case finding and completed treatment will give her bonuses. They provide, they identify cases in the community or active surveillance. That is, they don't wait for the patients to come to them, they seek them out. And then when the person is tested for, their sputum is tested, which is what you do, in either a government facility or a BRAC facility, then they provide community-based treatment. And the results indicate, the important thing here is that 92%, 93% are cured, and the default rate, which is the real thing that we concern ourselves with tuberculosis, is very low. For those of you who don't know tuberculosis, the reason that we're concerned with default rate, and is people stopping their medicine, is that this is a trigger for the development of resistant strains. So the reason that this was set up was to, in fact, reduce the default rate. How do you get the default rate to a very low level? Because if you can keep it low, you reduce the likelihood of resistance. And right now in India, there's a huge problem with the emergence of MDR, multiple drug resistance TB. And in Mumbai, and I'm sure elsewhere, they have found some cases that are even more resistant, which they call TDR, total drug resistance, or XDR, tuberculosis. Okay? The cost per case, as you can see here, is about 2/3 that of government, 64 versus 96. By 2006, the National Tuberculosis Program and BRAC, working together, government and NGO working together, had expanded coverage in this program to almost around 100 million at this point, with 78% case detection and 94% treatment success. So, beginning in '84, and then over a 20-year period, they expanded up to that level. Now, what is interesting about this program? One, it's community-based. It's door-to-door service. Okay? Secondly, and this is one of the most important elements that we're going to talk about, is a financial bond prior to treatment, which was return on the completion of treatment, but forfeiture on non-compliance. Now, what does that mean? Okay, I identify him as being positive. And it's more likely that it'll be a man than a woman. The ratio is almost 2 to 1. And I say, well, you can go to the clinic that's 1 kilometer away, or I can come to your house and deliver it directly. If I do that, however, you've got to give me, I'll make up a number here, 500 taka, 500 rupees. Which, when you complete your treatment, I'll give it back. However, if you default, so when we're signing a contract, you're going to lose the money. Okay? So you can stop treatment. I don't force you to do it, but if you do, you're going to lose your bond. Now, in the initial days, they took out a certain amount of that 500, we'll say 100, to pay for the work of the Shasta Shebika. Okay. But the Shasta Shebika gets a small incentive. There is intense supervision and quality control, and in this case, very strong support from government and donors. The Global Fund for TB is now giving money to BRAC to pay the Shasta Shebika so that you get all of your 500 back. Before, I gave you 400. Now, what if he's too poor? He can't afford the money. We go to you, you're the community. Say, lend him the money because he's a member of your community, and we'll back him. And since BRAC is a development organization and is there with other programs, they are a trusted organization. Nobody has ever been denied therapy. Now, you could say, I'll give you 500 if you complete. That's not the same as you putting up 500 and losing. As I said, the default rate is down to 1.3%. So it's an interesting concept. Some people have a great deal of trouble with this. How can you charge people for these drugs? You're not charging them for the drugs. You're charging them for the service. You're providing the service. The drugs are free, whether you get it from the BRAC program, or the Alien Foundation, or from the government. It's a service. We're writing a service contract. Okay? I want you to think about that. Think about what you think about it. So here's the Shebika, the average age 35. There are a lot of programs like that, selected by the village. Okay? Literacy preferred, trained to recognize, provides basic health care services for about 300 households. Okay, there are many programs. Underlying workers, this, that, and the other thing, that are sort of like. She does get, if she sells certain products, sanitary napkins, paracetamol, so on and so on, she gets funds for this. So, here in an urban slum, and by the way, delivery of care in urban areas is very different than rural areas. Much more difficult, actually, I think, because of the multiplicity of providers. So here she is labeling the sputum to be tested in a testing center. Here she is giving it to the villager. So she takes it. Here they are in a retraining program. BRAC puts in over 70%, over 7% of its total budget goes into training. Training, retraining. They have maybe 35 or 40 training sites throughout the country. They're simple, clean, hospitals, good meals. People come in for anywhere from a few days to a couple of weeks. And these centers, by the way, are used extensively by government as well, because they're well maintained, well kept up, and so on. And so they're not just there for government programming to come in, which may be every 6 months, in which case the thing falls into disuse. These are heavily used because it's a business. So you want to go there and run a conference, you put in a request, you get these rooms, you pay this amount of money, and so on. So it's used by lots of NGOs, government, BRAC, and so on. This is in Afghanistan. They are the largest NGO in Afghanistan. And in an urban program, you can enlist other providers, such as drug sellers, or you can have a DOTS corner in a hospital, where the same service is provided. This is the age and sex distribution, and as I noted, men have twice the incidence as women. Why that is the case, I don't know. Obviously, it used to be thought that there were fewer women because they didn't want to come forward because of the fear of stigmatization. But wherever people have looked, you find these sex ratios, gender ratios. So, treatment of sputum-positive cases, 2003 to 2009. In 2009, they treated 72,000 cases. And so it's not what I call a boutique operation. This is a major program. 72,000 people, 92% cure rate, and default is only 1.3%. So of the 72,000 people, only about 1,000 have defaulted from the program. That's quite amazing, actually. There's quality control, so they do control at the laboratory level. 50% of new sputum positives, 5% of negatives are cross-checked blindly. Again, supervision. Patients with side effects are then referred to the Upazila Health Center. So you don't use it. This is not a doctor program. This is a program that's managed and run at the village level. And you don't need doctors to run a DOTS program, except to be there when you have complications and to decide on the initial therapy. Government provides the logistics and drugs, so it's a very much of a public-private mix in this case. Performance and drug consumption reports are sent to the National TB program, so it's not a competition, but rather a collaboration of sorts. Regular contact with government and WHO, monthly coordination. So throughout the system, there is there's an intertwining. Okay. Now, what is the impact? After 3 years, the prevalence of TB in program areas is half that in some non-program areas. The detection rate of new sputum was 63% in 2002 in areas where the program started about 5 years earlier. Female-to-male ratio, I noted, and the cost is significantly less in the BRAC program. Now, what contributes to the success of this program? And I would view this as a successful program. Okay, very high identification of cases, very good treatment success, and extremely low default. They learn from the pilot projects with independent research and evaluation, and they involve community health workers with an incentive system for case finding. So if she finds a case, she gets a small bonus. For that, the bond money, which I want to come back to and ask you what you think about this. Simple treatment, which is at the doorstep. Free drugs, and a reliable service. Because when I start treatment, we're doing a contract. He commits, and I commit. And how do we know that I commit? Because I'm being supervised twice a week by the Shasta Cormier. Program management emphasizes teamwork and supervision throughout, and availability and use of external technical assistance. This program was set up because of Dr. Ishikawa from Japan. So they made use of the Japanese work in tuberculosis, which was continued in the developed and the wealthier countries. Japanese have always been strong in TB. And so they went to them for their advice. So let me stop at this point. And I'd like your opinion. What do you think? What do you think of this bond system? Do you think it's fair, that it's equitable, that it's doable, or is this something that, for reasons, what's your opinion of this? Yes.
What is the motivation for people to make?
What is the why should they make? Okay, I give you an option. I say you can go to the government clinic anytime you want. You don't have to. Well, there's an awareness level, number one, and I think it makes sense. What would you rather have somebody come to your house every day at 7 or 8 o'clock and give you the drugs? Or would you rather get on the bus, take a taxi, go to the government clinic, which may or may not be open? What would you rather do? Now, to do that, of course, you have to agree to a certain set of circumstances. You have to agree that you will put up funds for that. And I submit to you that people are quite used to doing that. We all have cell phones. All of us are on different cell phone programs. Some of them say you can have the cell phone free or a very low cost, but you have to stay with our program. And if you switch to another program, you got to pay for the cell phone, right? There are lots of programs that are outside of the health system that make use of this idea. That is, we'll give you a discount if you use our product. If you switch products, you got to pay more, right? So I'll buy that. So that seems to be the experience. I mean, the fact that 100 million people or 95 million people are doing this speaks to that there must be a market for it. There must be a market for this, right? So that's all I can tell you. Some people say, well, why do you need the bond? Why do you need the bond? You really need it. Couldn't you just start the program this way? Possible. I don't know the counterfactual of not asking for the bond, but so far it seems to have been very successful. That's all I can tell you. That is, there is a cost to defaulting. There is a penalty if you default. Because remember, that's how it was set up. It was originally set up as both a delivery, but how can we reduce? The default rate was at that time maybe 20%. And I'm going to talk about AIDS a little later. And the default rate in AIDS, or the loss of follow-up, is over 20% in the best programs.
Yeah, I'm interested still. There are other factors motivating seizure. Priority, their perception about TB should be very high. They know that awareness should be high.
Well, I think people know about TB. If
you look at the context, the Bangladesh context and the Indian context,
it's not different. It's not very different. Bangladesh, I mean, somebody drew a line on a map 60 years ago and said,
Bangladesh is poorer than India. So in terms of economic, social status wise, it's
all
similar
there.
thing.
It's all there. There's no.
We have a DOTS program. We have ASHA workers, just like we have free medicines. So if you look at, but our program, if you look at the Government of India program, which is supposed to be one of the best in the world, its cure rate is less than 75%, high default rate, etc. etc. So that is the thing we have to keep in mind. That try and ask questions. Yes.
Yeah, please. Be as critical or as praiseworthy as you like.
My opinion is I used to work in a place called Nagaland, which is where we get a lot of migrants from Bangladesh who work in the field. And the thing about this bond program, I think somehow even the state tuberculosis officer and district tuberculosis officer heard about this and heard about how it affects people and how the default rate is very low. The problem, I think, is not really with this concept of bond, but it's about who is implementing it and their understanding of why it is being done. Because we had some district tuberculosis officers, like in Liverpool, who adopted the same program, but unfortunately, she did not inform the rest of her staff exactly the motivation behind it, the reason how to do it. And the problem with that was in Nagaland, they have very high default rate, as close as maybe 60-70%.
Wait.
The highest reason from the DOGS program.
Right.
The highest, the private practitioners do not follow this. We have a very high HIV rate, which makes it even more dangerous. And one of our core groups that defaults are the Bangladeshi migrants, because eventually they leave after 2-3 months before the
And they go back.
and there's no way of tracing them or a formal system by which we can inform someone that it can happen. And the problem with this was that it started a lot of rumors around in the press with the private practitioners, where on one hand the government of India says we give free drugs to our patients, where people started saying that, but in Nagaland the district tuberculosis officer is taking money from the patient. So that became a political issue. Then it became an issue saying that for patients who could not afford, this kind of a community support program was not established. So what would happen was the person at the dog center or at the dog's district office or at the various clinics, they would demand money from the patients and you must give it. Otherwise we will not, we cannot support you. So the problem there that came, while she herself saw that for some people, this helped in improving compliance amongst those who were ready to come to the government. The fact that there was this confusion about how it is and why is, who is doing what for what reason.
That's
It
very
created a lot of political issues.
You
because
have trust is obviously critical for the whole operation. If you don't trust the person who you're giving the 500 to, or whatever the amount is,
it was 500.
or whatever, then of course the program is not going to go. For example, she can take the money and then she gets transferred, and the next guy comes and says, I don't know about the 500.
Exactly.
What are you talking about? And the money is not returned, and the rumors start, and the program collapses. Trust is critical to this. For them, of course, they have so many other programs that are going on. This is just one element of their program, which includes microcredit and cooperatives and many other things. And the brand, the BRAC brand, and branding is very critical, is a trusted brand. So but your observations are very, very interesting. That is, to try to do this on a small level is fraught with difficulty.
Well, but I mean, there are various other reasons which play just as important role beyond just the design of the program itself, because they may not really be a problem with the design, but when you're trying to implement it in a different context, political support, awareness, community support,
But were they actually going to the home and giving the drugs in the home?
So that's the other thing. So in Nagaland, just like I think the rest of India, dots, in some places they do door-to-door delivery. But the problem is that often you have a dot's corner or a dot center, which could be a pharmacy shop or a government school or something like that. And people are still expected to at least walk till there and go back.
Well, in an urban setting, that's not such a problem. In a rural setting, especially in Nagaland, that must be a problem.
Actually, I think there the problem in the rural settings was not much of a problem. Because in the rural settings in Nairobi, the person in the dot center would be someone from a local. So for her, it wouldn't be a problem in going around and giving people. There, the trust and the support is much stronger. But in an urban setting, it has to be coordinated with where the person is working, and urban health workers are not trained and are not as supported as the rural ones.
Well, some of their programs in the urban area, for example, there's a huge garment industry there, and they've taken the program to the factories. Although in some of the factories, the owner isn't very keen on it, and in some of the factories, the people don't even want to tell you they have it because they'll get fired. So to make it work in a factory, you have to have an owner who says, yes, I'll give a week off or 2 weeks off in the first stages. You don't want somebody in the factory when they're coughing and so on. So you give them, I think it's 2 weeks, leave, and then they can come back and the drugs are delivered. But you have to have the cooperation of the factory owner, and then you can convince people, yes, come forward, because if you come forward, we'll deliver the drug right here to you in the factory.
Actually, I just started up one thing. What Anna was studying, actually, even if you're working in Bangalore, in one of the slum areas and on the wards, we are selected as our job, an area for work. And what we notice is most of the in urban area, in the area where we work, the patients are expected to go to the urban health center to collect the medicine. It's not that they're not getting the service in the doorstep by the link workers or the AMs. They're expected to come. If they come, they get it. If they don't come, then they don't get the medicine. So this is how even in Bangalore, in the area where we work.
So they stop coming, they stop coming.
They stop coming.
And nobody follows up.
They say we follow it up, but to what extent is still a question.
Well, usually we don't even know where people live in the urban areas.
So that's one thing. And just relating to the bond, how difficult is it, how different is it to have this community group for somebody who cannot afford to pay the bond in an urban setting, to bring the community together, and in a rural setting, I understand it. So how challenging is it to do that in an urban area?
I don't know, but I think all of this depends upon the attitude that you bring in. The vast majority of people can afford it. You have to set the price so that the price, it hurts you if you lose it, but it's not prohibitive for you to give it. So 500, whatever that amount is. My guess is, I have to go back and ask them, but my guess is that well over 90% can afford the bond, 95%. There is a group of people who cannot. The challenge then is to how to incorporate that group of people. You don't want to, this, the old expression, throw the baby out with the bathwater. That is, what about this other 90% that you can reach, 95%? So the challenge is, well, how do you reach that other? That should not dictate the program. In my view, the exception should not dictate the program. If you're reaching 95%, then that's strong, and then you figure out a way to reach that other 5%. That other 5%, you could say, well, we'll assess your needs, and if it's below a certain point, then we will subsidize you. That's one possibility. In other words, you could say, here's 500 rupees, we'll put it over here. You complete your treatment, we'll give you X amount. We'll pay you to do it. Now that's different. The other group is not getting paid to do it. The other group is, you put up the bond, you're just getting your money back. Okay? So you would have to figure out some way within an urban setting to deal with people who don't have the means to do it. But your program should not, in my view, I'm just giving you my view, not there, but the program should not be designed for that 5%. The program should be designed for 95%, because that's where most of the cases are coming from, and that's where most of the default is occurring. And then we figure out a way to handle that other 5%, rather than the other way around. That would be my approach.
Because we are also having a program there where we're doing free computer training for school toppers and
Right.
8th standard. And he said this, saying that you have to pay 200 rupees at the beginning, and you complete the course, and then we pay you back. We are doing something
Right.
like this. But what happens is most of the time, we come across that many of them can't even afford to pay that. So they would say we will come next for the next batch. So we'll come for the next batch. Then most of the time we'll be in a dilemma that we know they can't.
Is it sure that they can, or they just don't want to do it?
No, we usually assist. No, we have a link field about this.
So then you got to figure out some way. How do we get past that 200? It's setting it aside, or giving people a bonus, or I think you have to play. That's why you have to do pilot studies. That's why you have to do a pilot study to sort out, well, what's the best way to approach this? And you may go through 2 or 3 different.
We have done the 3
Trials.
batches, so we are also learning.
Yeah. You have to do pilot studies. This program that I'm outlining for you is the result of 4 or 5 years of trying out different things. They didn't just come up. Yes.
Just a question related to those pilot studies. I was wondering whether there were any pilot studies dealt with not formal community governments, but someone in the community who also provided. Because some of the things that happen to try that.
Well, the Shebika is basically a community member. She's not trained to do surgery or make all kinds of.
I know that, but someone who's even less formally.
So a family member.
Yeah, or a shop owner.
Yeah. Well, you saw her. Yeah. You could do that. You could do that if you felt that was a. The Bangladeshi situation, of course, may be different than other parts of the country. It's a highly, intensely populated area. There are 150 million people living in the size of maybe a third the size of Karnataka or something like that. So you go into a village, and within a very small radius, there's a very large number of people. Okay, so so one worker could do 300 households. You couldn't do 300 households if you were living in Kenya, or God knows where, or Rajasthan maybe. I don't know the settlement patterns here. But she could do it because within probably a half-hour walk, there's 300 households.
No, I understand that. I was just wondering whether initially when they set up the program, they said they did several pilot studies, whether they tested it against someone who's not someone like that.
I don't know.
Because they don't know They'd rather have someone less.
But these are all neighbors of theirs. These all of these people are their neighbors and friends. They're not outsiders.
There's a kind of not a stigma. It appears to be now that the stigma is very different.
Well, I think my own feeling, is that the concept of stigma has been grossly overstated. Everybody knows everything in the village. If you've got a cough and you're losing weight, and your cough is bloody, people know what you have. If you have the most stigmatizing of all conditions is mental illness. I think that the AIDS approach has been grossly overstated. Because I think that in an Indian village, there are few secrets that are there. Very few secrets. Women talk about sex, and, particularly among women. I know studies that people in the urban areas say, we can't ask those questions. People will be very offended. And then you go out to the village, and the women have got broading jokes. They talk about their husbands who can't perform, all sorts of things that are going on. It's the middle class that's the problem, not the people living in the village that's the problem. It's the middle class that got this idea that, we can't talk about that, better not do this, better not that. When you live in a village, I talk to people who do this sort of work. There are no secrets. There's nothing that's, you're living in a house that's got a wall this thick, and one house is next to the other. People know. I think that's one observation. Secondly, if you're showing people that they're going to get better. I remember when I first went to Bangladesh in '67, there was a cholera outbreak in one part of the country. So we went down there. And nobody was coming into the hospital. We knew there was a cholera epidemic. And why? Because the hospitals in the past had never provided care. And people died, so they'd say, I'd rather die at home. And I remember our workers went into the house of the head man. You heard that there was a case. And they literally absconded with the patient, forcibly took her out. This is '67, so a long time ago. She got better. She survived. She went back, and suddenly we got all these patients. Because of this belief that why bother because you're going to die. I'd rather die with my family than die in this, impersonal place. I think, they treated 73,000, so somebody's coming forward. So I think, give me my personal opinion again, that the issue of stigmatization is real but overstated, and we should not use this as an impediment to implementing programs. That's a strong statement. But we're debating these things. That's something, by the way, that a pilot study is going to find out. Is stigmatization so strong that people won't come forward? Now, I know, because we're talking about the early work in Goodwood, and people would oftentimes leave the hospital to die at home. At least that's what I was told, and this was a problem, especially for people who have a curable condition. I think that probably over time, this may have gone down a bit, that people who have a curable condition will stay there. But if they have a malignancy that's not going to get better or go away, then they understand. And it's this negotiation between the medical staff and the people themselves. And I would suspect, that over time, people began to stay around the hospital if they felt that this was a curable condition. If they felt that it wasn't, or past history said no, or they were abused by the health workers, then they felt. As we would do. Yeah?
You mentioned about the costs, saving program. $64 for BRAC and 96 when the same thing provided significant around $30 difference. So we are costing also looked at why is it that?
I don't know. Again, I'm going to send this book down and you'll take a look at it. I'm the griot. I'm the one who's spreading the message. So the details of this, I would suspect that because salaries are lower, because payment is lower, because the supervisor are not only supervising the Shebika, but they're supervising other things, so that there is the spreading out of costs to other programs. Okay, that's what I would suspect. Because the drug costs are the same, so it's got to be personnel. Right? Yes. Drugs are free. Drugs are the same.
What is going to be donor? Is there a large amount of donor support?
The donor support comes in the early days of donor support. The donor support is for the drugs, and now the Global Fund is saying that you give back all the money, and we'll give the Shebika 100 or whatever it is. Okay, it used to be that they would take that money out and give the people 400 back, and that was not a problem. Now, as you will see when I propose this for HIV/AIDS, I might as well talk about that now. What about AIDS? The problem with AIDS is that it's a lifelong condition. This ends in 6 months. Right? AIDS goes on for who knows. People say, how could you do it for that? Well, you could put this into a revolving fund. You could deposit the 500 rupees in a bank, and every 6 months you would get the interest. But if you defaulted, you'd still lose the 500. So you could do it, you could roll it over. Okay? You say, well, we're going to keep the 500 here. Every 6 months, we'll give you whatever interest accumulates. But if you default, you're going to lose the 500. Or you could keep everything. And why? And what about people who die? Well, the family comes and says, we want the deposit for our uncle. Because when he signed up for the program, he listed us as his beneficiary. I want to move from Bangalore to Madras. Okay, you can move. Here's a contact that you can use. I don't want to. Fine. Here's your money back. But we now know why you're leaving. We know that you're leaving, so it's not lost to follow. I don't like this drug because my skin is turning yellow, or this and that. We send you to the doctor, and the doctor said, I'm sorry, he's having a bad reaction. We don't have a second-line drug. We can take you off the drug, get your money back. But if you run away and don't tell us, you don't get your money back. So you would go from a 20% default to 25% default to a my view, a 2% default. Because if you die, the beneficiaries would come forward. We know you died. If you had a bad reaction, you would come to see us. You would see the doctor. If you decided to move, we'd know.
It's 12 o'clock.
So instead of a 20 to 25% loss to follow-up, I would postulate that you can. But we'll come to that. I want to show you one other program. Any other thoughts? All right, let me show you another. Okay, one more. Go ahead.
I just had a general one on your lessons for Shebika. So I have done research on innovation, dynamics, and TV recording, and that's fine. And very often when people come up with good ideas, and then the question is not scaling up, and they maybe present to the government, the main critique would be, oh, this is all dependent on you as a personal outstanding,
Right.
super innovative,
Right.
great individual. Now taking into consideration what we heard about the Naga experience, should in your list of lessons also be something about that would address that point, or how this was said that there's a brand, BRAC-A.
Yes, no question about it.
So,
Well, I think the way I would think that you would deal with it, first of all, you have to have in your mind that I'm not going to just do a little thing and then maybe if it works. You have to think about it from the beginning. The reason I say that is that you will constantly then throw off all the things that are unnecessary. Do I really need to find out this information? No, it's not going to help my program, so I'm going to discard it. You've got to keep your eye on the prize. And the prize is, well, sometimes you can't do it. There's no question about it, but sometimes you can't do it. It just doesn't lend itself to a larger issue. But it seems to me that if you want to, if you start out with that kind of mindset, then you will constantly try to figure out, well, this is an impediment to moving this forward. So we've got to figure out how to get around this. Let me show you this other program and see what you think of this one.
I have one question.
Yeah, please.
We know that most of the people are not the who are your treatment outcome cured at what extent food and nutrition supplement is implemented?
It's not part of the program. It's not part of the program. And if you made it part of the program, you would severely compromise the program. Because now you're adding a whole other layer that, yes, everybody who's chronically ill needs food and needs better nutrition. But if it becomes, in my view, if it became part of this program, it would go. But they have other development activities. There are microcredit. There is loans to the ultra poor. But that's another issue. Should you be giving food? Well, you should say you need more food. And so on. But as far as I know, this has never been part of the program. And if I was to advise, I would say don't make it part of the program because you will severely compromise the main goal, which is to cure people with tuberculosis. I think. All right, let me take up another one, and we can come back to this. This is a different program. This was done and completed. And the purpose of this program was to educate all the women in Bangladesh on how to make oral rehydration therapy at the home. Now, this was begun in the early 80s, before before packets were widely distributed. So this goes back in time, okay? So this is a child who's severely dehydrated. You can see his eyes sunken in his head. Here's a child. You see the fontanelle is depressed because of severe dehydration. And there are many causes as to why diarrhea is a major problem. This is a water-based economy, and so water is everywhere. This is a ghat that I know many of you know, where dishes are washed, clothes are washed, water is collected, and so on. This is not the case now, but these are historical photographs. Children swimming in a tank, and tanks are throughout Bangladesh. The whole country is as high as this table. And so when you want to have land to build your house, you dig down, and you take the mud, and you build up your house, and what you have left is a tank. And here's a tank, and the kids are swimming, and unfortunately, right next to where they're swimming are privies. And we clean the baby's bottom with our hand, thinking that the children are the most innocent, and yet they're the ones who spread most of the disease. But this is all. So, at that time, now that you wouldn't see this scene now, because all the boats in Bangladesh are motorized. So somebody comes in by country boat, or by village ambulance, going across a bridge like this. All of you have seen these, I think, I'm sure. Right? So there are scenes like this from rural Karnataka, I'm sure. Or by bicycle rickshaw. And so what all of these things do is they delay your visiting hospital. Because if it takes you an hour or 2 hours to get there, and then you get there, and there may not be anybody there, and so on. So people delay, and in their delay, they become sicker and sicker, and so you end up with more. So going back to the mid-60s or earlier, the desire was always to try to find a way to take therapy into the home. Okay? So if you could rehydrate somebody at the house, you would prevent severe dehydration and maybe even eliminate people coming into the hospital. So this is based on the research that I did back in '67. So you would have lots of beds of children like this with the, and this, you can see how old this is. This is the Pakistan Sito Collar Research Laboratory. So this was 1967 when Bangladesh was Pakistan, East Pakistan. And this was an adult patient who might, in this case, took 100 liters. That would have been 4 months of his daily wages. Okay? So cost, accessibility. We didn't have scalp pains in those days, so they were oftentimes reused. This is a collar cot. It's a cot, beautiful piece of appropriate technology with a hole in it, with a plastic sheet that covers it, with a sleeve that goes into a bucket. So instead of the person going up this collar, you could lose a liter an hour. All of these early studies were on collar. Patient defecates, it goes into the bucket, and because it's plastic, you can see how much they lost. And the whole strategy for treating watery diarrhea is you give people what they lost, but you give them an appropriate solution. And how do you know when they have enough fluid in them? What's the easiest sign? Might be doctors here. Urine. You're passing urine. You don't need to do central venous pressure or anything else. If they're peeing, then they're hydrated. If they're not, then they gotta push a little bit more fluid. So it was stripped down to its essence. Okay? So here's the lady severely dehydrated. You can see the skin on her belly comes up. This is called skin turgor. Okay? Her hands become like somebody who's done the wash for a long time. They get called washing woman's hands. Her pulse is very fast, or you can't even pick it up. And she'd be breathing like this. Because she is, in medical terms, acidotic. Her blood is acidic, and so she's blowing off CO2. Correct. I'm sorry, I don't mean to, for you non-medical types, physiologic doctor, but that's what's going on. Okay. If she's in shock, she gets intravenous fluid, and then immediately switched over to oral, and that's what she looks like the next day. From that to that. So the early studies showed that you could save up to 80% of the IV that was required. That meant instead of treating one person with 10 liters, you can now treat 5 people with 10 liters. So you can extend the use of the intravenous fluid. The next question came up, could we take it to a rural area where there was even less of an infrastructure? Here's a little girl, treated by her mom. Now the family is getting involved in the care. Again, these pictures go back to the late 60s. And there she is the next day. So by involving the mother, you are training her to be a provider. Just to remind you, these are pictures actually from Tamil Nadu of that diarrhea contributes significantly to malnutrition. I won't go into why. So breastfeeding should continue, and mothers should continue to feed their children. So that's a basic 2-minute primer on diarrheal disease. Okay. The first large-scale use of this, really large-scale use, occurred in the Bangladesh War of Liberation, where this is a refugee camp near Salt Lake in West Bengal, and you can see that people were essentially living in these sewer pipes that had been put there because they were going to do some large construction. 10 million people fled across, and when 10 million people go across and get together, although I was just at the Kumbh Mela 2 days ago, diarrhea is a major problem. Although at the Kumbh they have put in all sorts of ways of protecting the population with good water sources. Remember, this was 1970, 71. So we're talking 40 years ago. We've fortunately learned an awful lot since then. And now we know that 12 million people are going to come to the pool, so we plan accordingly. We plan for crowd and water and so on. And they're not going to stay there but maybe 2 or 3 days. This they had no idea. So they can erecting tents, they can water, sanitation, crowd control, all sorts of things. Contrast that with this situation. So then the next question came up, well, how do we get this to people in the community? How do we do it? One way is to take the salts and put them in a packet. Now, what determines the chemical composition of any fluid that we use? There are 2 components, right? One is the salt and the amount of water you use, right? If you put one of these in 500 cc's, you'll get a different solution than if you put it in 1,000 cc's, and so on. So here was a school teacher. He was distributing this. But what we found is that when a man was distributing it, oftentimes women wouldn't come forward. And you still have the problem is that this is for 1 liter. So he said, well, let's do spoonfuls of, because this is made up of table salt, sodium chloride, soda bicarb, potassium chloride. Potassium you can find in green coconut, bananas, tomatoes, citrus fruits. So we said, well, we'll take spoonfuls. Well, which spoon? So then you make up a standard spoon with directions. What's the problem with this? You got to be able to read it. And you have to have a glass that's this size. Because if you misread it, you'll put the salt here and the sugar over here. And the difference in amount is quite huge. Now, all of this is being done through iteration. This is from a talk I gave called Taking Science to the People. That as you continue to try to do things, you say, well, let's try this. How about this? So you say, well, we'll use a standard measure. This is from Guatemala. Which one is the right one? We don't know, because there is no standard measure. And you can say a Coke bottle. Which one? This size? Family size? You know, what is the standard measure here in Karnataka? Is there a standard measure? I don't know. That's something you would find out through through field work. You could provide this for people. You give everybody a standard. That increases your cost. Because you have to make all of these containers, 1 for every family. That's 13 million of them, and distribute it. But that's another possibility. And as you get more money in your country, you could move to this. But at that time they did it. So BRAC, back in the early 80s, said, let's see if we can literally put the treatment in the hands of mothers. And they figured out, through chemical analysis, that if you took a pinch of salt and a scoop of sugar or gourd, you use gourd here, right? Which is jaggery, which is actually better because it has potassium. And you put it in 500 cc's, you have a reasonable approximation of an effective oral solution. Now, you still have the problem of 500 cc's. How are you going to get around that problem? Well, what they did was they trained a group of basically not just the Shebikas, because they were not staying in their community. They went from community to community. And they worked it out so that there were 10 points that they needed to remember, which they eventually reduced to 7, because they figured there were 3 of them that were not necessary. And the worker went from home to home, teaching mothers in her home how to make it. Now this was funded from from external sources. This was not funded through BRAC-A. I think the Swiss and I think the British. Swiss were a major donor. You still have the problem of 500 cc's. So she could give them a container, or what she did was she brought her own 500 cc container and she told the mother, bring me out a pan, something that won't break. She pours the water from here to here, and she scratches a mark. Now she has a 500 cc container. Literally taking science to people. They also found, when they were in the community, that men were, of course, involved in decision making. So if you just taught the mothers, you were missing part of the decision making. So they ended up, instead of spending 2 weeks in a community, they would spend a month in the community and spend time teaching the men as well. Then they found out later on that you could actually teach 4 mothers at the same time using flip charts. What else do you see in that? Who are also learning. Now you wouldn't see that now because a lot of these kids are being schooled. The children learn quicker than adults. Now here was the fascinating part of it. Because then the notion came up, well, how do we know that this is working? How would you determine whether this program was effective? They're trying to teach all the mothers in the country. What would you do? What would you measure? Yeah, you could say, you know the 7 points, and can you make up the solution? Now, are you going to ask each and every mother? No, and you want to be sure that this message takes. So you go back maybe a month and a half, 2 months later, and you take a, say, 10% sample. Now, they knew how many people you had visited. Because you had a certain area. You were only allowed to see 10 people a day. You had to go from 1. So in a month, you saw 300 people. So let's say I measure in a month. I take a 10% sample of 30 people. So I go to the house. I have a completely separate team that does evaluation. And I ask a worker here, or you, worker. I don't ask the worker, I ask the mother. Tell me the 7 points. If she knows 6 or 7 and can prepare the solution, it's recorded as an A in the book. 4 or 5, a B. 2 or 3, a C. She can't prepare the solution. Now, I now know of the 300 that you trained, what percentage got this, this, and this. I can assess the level of knowledge. I can't force the mothers to use it, but I'm at least assuring that they know about it. Now this was, the brilliance of this is it was used, this information was used in another way. How else might you use this information? What else could you do with that data? I find out that 90% of the people that you trained were recorded as an A, and 10% recorded as a B. What else can I do with that data? What would you do as a data? What? You got this data. What else are you going to do? Yeah.
We can identify what was the reason that 90% got that messages when you were going back.
Okay. You can do that, but you work this out through your pilot program. Cross-learning. This was used to pay the salary of the workers. So for every A, the worker got 5 rupees times 0.9 times however many you saw. So the workers paid on performance. Not a salary, So if you do a good job, so you don't want to say at the end of the month, boy, we really saved a lot of money, nobody learned anything. You want to maximize it. You want it so that 100% of them get an A. Now, what does this do? This then encourages your workers to come up with all sorts of innovations to increase retention, like teaching the men. That came from the field workers. Okay? Like the following. The only female workers that had been in some of these areas were family planning workers. So some of the people said, well, these are just family planning workers. They're trying to, there's something funny going on. So the workers said, what we need to do is to taste this, to show people that this is perfectly all right. They did it. So by linking salary to performance, you also weed out those people who don't perform. Right? Somebody who consistently doesn't do well, you either retrain them, and if they still don't do well, then you sack them. What's the point of having somebody there who gets a low salary? You're not saving any money. You're losing money. So salary is tied to performance. Innovation is tied to performance. And so the system then reinforces itself. And so over a 10-year period, they trained 13 million runners. Is this a good idea? No. Over a 10-year period, 12 million were taught. Based on a home visit of a female OTEP worker, who, by the way, then, when this program was ended, the genius of BRAC is they're thinking like a good chess player, 2 or 3 moves ahead. What are we going to do with 1,000 women who are out there doing this? Develop new programs. Knowledge persists in the population. In some areas, they were doing a literacy program. They went back. In the literacy program, they asked kids born after their mothers were taught about OTEP, oral therapy. And about 85% or so knew all about it. So now the knowledge became part of the culture. It's now embedded in the culture. Bangladesh has the highest use rate of ORS. Again, institutional division, going back to the first slide, pilot programs, interventions are kept as simple as possible. For example, what if the water isn't good? Should I boil it? No, because that adds another dimension. That means you have to have the fuel to boil the water. People say, well, I can't use it because I don't have the fuel. This is the water they drink. Get the best water they drink and use that water. Okay? Train prior to scaling up and apply the lessons. Appropriate management. Management was very appropriate. Stripped of all doodads. Evaluate, advocate. From Mr. Albert Einstein, Professor Albert Einstein. Got to keep things as simple as possible, but not one bit simple. So how do you do that? And there's a third book that came out called The Simple Solution, which discusses this program, which I'll send to you as well. So you're going to get a packet of things. So one of the things here, if you took an IV use and ORT use at that time, the effectiveness of IV may be 98%, and maybe 75% for ORT. I'm making these numbers up. These are not the actual numbers. But when you add access, diagnostics, compliance, adherence, community effectiveness, ORT comes out much higher. So it's not the initial effectiveness at a nice hospital like St. John's. It's what happens when you're out there in the village. That's what matters. this is other stuff. Okay. Well, this goes back to the question, could the BRAC experience with dots, going back to the first presentation, be applied to case detection and treatment of other diseases, especially those requiring long-term therapy? I've given an example here of HIV, but what about hypertension, diabetes, and so on? But let me leave this for a moment and see if there are any questions on the OTEP program. What do you think of paying workers on the basis of how much the mothers earn? Now, you've gone through and you've figured out through your pilot that every mother is capable of learning this. You can't say, well, it's not fair because he's working in the high income area of Bangalore and I'm working in a poor village. They've decided, they've determined through their field exercises that every mother is quite capable of learning this. Okay? Otherwise, it's not fair in your assessment of the workers. So it's not the education of the mothers, it's the quality of the education provided by the workers. I remember there was a paper that came out around this time. Some American group looked at American nurses based in Guatemala. And American nurses didn't do a very good job of making the ORT. And so the conclusion was, how are you going to teach villagers to make them? But these American nurses, all of their can't do it, how are they going to do it? Well, it wasn't that the American nurses were stupid. It was how they were taught. It was the quality of the education. So before you dismiss something and say, people aren't capable of it, ask yourself, were they properly trained? Were they properly educated? Whatever term you want to use. Was the information disseminated in a way that was accessible to them? Rather than first blaming them and saying, well, they're not capable. They're illiterate. They're poor. Poor people and illiterate people can do some extremely complicated things that you and I only have a clue as to how to do. You go up to some of the Adivasi areas, they can survive in the village, in the jungle. You put me there, I'd last about 2 days. If I wasn't eaten by some creature wandering around the place. So who's smarter? Who's smarter? Me, with all my degrees, or them? Well, if you're measuring survival rate in the jungle, they're a hell of a lot smarter than I am. Okay, let me open it up for discussion. We still have another half hour to go. Are you guys getting bored? Getting bored of this?
What is interesting is that today Bangladesh, in spite of its poverty, has overtaken India in terms of child mortality and infant mortality. So we don't know, we can't say this is one.
No, I mean this is one of many
reasons. But so the fact that today children don't die of diarrhea, I don't know what the status of pneumonia is, but diarrhea and pneumonia are one of the two main killers of children. If you're taking care of one of them effectively.
And both of these programs have been reduced to essentially management issues, right? You work out all the medical stuff, you sort it out, you take away what's unnecessary, you keep what's necessary, you provide the backup at the level that it's going to be effective, but then you have to set up a system where you can deliver the product. Whatever it is, education on one hand, treatment on another. Because one is an education program, the other is education and treatment. Other thoughts?
What are the island then now? In the ORS, we know that. They were living in the same time. They already there, it came up with drugs. Diarrhea was all the way in sleep. Similar thing. Because and now they're discouraging the use of homemade.
Well, they're saying you do what you have to. What's very interesting is that the packet, I don't know, what is the size of the packet in India? For 1 liter? Okay. In Bangladesh, the size of the packet is 500 cc's. Why? Because the knowledge became so pervasive that people knew what 500 cc's cc's was, it was designed for 500 cc's. So if you buy an oral bag in Bangladesh, it's a 500 cc bag. Has anybody figured out whether everybody in India has a 1 liter container? Or they know what a 1 liter container is? Do they have a 1 liter? In this country now, everybody knows it's 500 cc's. Okay? Which is about half a seer for those people who do local measurement, which is used, a seer is used in measuring milk. So the knowledge became so pervasive that in this country, the pharmaceutical industry changed the product. It's pretty cool. Yeah.
This, for me, there's one other aspect of this. One is being that when you're in a community program, when you're doing community-based activities, community outreach, or you're looking at how to deal with diarrhea in the community, you have a certain understanding, and you have a certain understanding not only of the disease, of how it is in the community, the prevalence, and the limitations and the resources available. You know that for a mother with a sick child in a remote village, the best tools she has is what is available for her in her house, her knowledge and her understanding.
Right.
The problem often comes, I think, when it comes to, let's say, the medical doctors, like for instance, pediatricians, who, when they are in their clinics and they hear about or talk or discuss about these programs, they often measure it against, like what you were showing about the IV fluid and the dots thing. They compare effectiveness, efficiency, and is it good, bad, should they advocate for it or against it, with their understanding of what should the exact composition of the salt be and what are the possible effects on the body of the child. And I think the similar experience is happening in the discussion with respect to neonatal care as well, where you have some NGOs advocating that maybe you can train community workers and mothers to identify when a newborn is born at the house, and that these are certain danger signs and certain signs.
The work of
giving care. Exactly. And you have a strong voice from the medical community, from the pediatrics community, saying that you're going to put them much more at risk by having women from the village doing neonatal care when it's something that needs to be done by trained medical doctors who should have so many years of experience and things like that. So I think that while there is no denying that when, let's say, a country sees a priority, then it's able to make certain decisions. The problem is when it's been there long enough. Like for instance, in India, when you know that diarrhea has been killing children for the last, we've been talking about it, I know, in community classes, education, medical school, for the last 20, 30, maybe longer, 50, 70 years now, is how the medical, with the dominance of the medical doctors and the voices with respect to what kind of policies come forward, is their understanding of a therapy like this versus a therapy in the hospital. That you can't really, I don't know what the answer is. I have my own biases and opinions on this as a medical doctor. But often for me, I found that it's the medical doctor's medicalization of treatment that causes more of a problem rather than the design or whether it's possible, not possible, the economic arguments, etc. It's more of that concept that to treat something very serious, there has to be a medical component to it, and that requires, hence, a medical doctor to be sitting somewhere making a decision.
So let's go into another area. So should all of the people deliver in the hospital, JSY?
Exactly.
Or can you effectively deliver at home, provided that somebody is well trained at the home, and there is quick access to another facility which will provide good care. So that's a real dilemma, right? Because India's now pushing everybody to have an institutional delivery. Do you need that, or do you need good? Is it better to provide good care in the home with access to these other issues and problems. And because a lot of the early stuff on JSY is people, they're getting horrible care in the hospital because they scaled up but weren't prepared for the scale up. Right? They didn't have enough people trained, so they got out, everybody got interested, but then what? You know, it's like, you know, all of these people going into this little narrow corridor. Was that the best way to go? Well, the obstetricians kind of would say, get it to the hospital. Western evidence is, get it to the hospital. Interestingly, there's another project I have brought up called Minoshi, which is delivering women in the urban slums in very, very basic facilities. Very, very basic. But with access to better facilities. Okay? So the birth issue is another one, which raises a lot of these very important questions. How much do you medicalize the problem?
I think we've, I mean, I know when I went.
See, here they had no choice. I mean, basically,
Exactly.
there was nobody out there, so there wasn't even an argument about it because the doctors weren't going to go and the people weren't going to come and everything else. That's pretty clear. But now we're in a situation where that's not necessarily the case, where access is there. I mean, roads, cars, 90%, 98% of women in Kerala deliver in hospitals. Now they have roads, they have hospitals, they have, you know, home delivery really isn't an option. And people have been acculturated to believe that you have to deliver in the hospital. It's about 98%. But it's a different situation. What do you do with poor areas of Northern Canada?
I think similar things also coming, at least from my knowledge, also came into malnutrition for some extent. Where you talk about, like, for years we had really high rates of malnutrition among women, pregnant women especially, which talked about more in children. And then you have approaches where they want to bring out mixes and special nutritional supplements, even for patients with HIV, because that would mean that they get more energy-rich food, and then they want to create a system by which it can be distributed out to people and give it to them in a certain packet, and they use it with certain kind of food. And then with it comes this requirement of saying that only the malnourished child should eat it, not the other children of the house, or not the mother or the mother-in-law, who may also have a certain level of malnourishment, but it's not for them. Only this boy or this girl gets to eat this special energy that his brothers and sisters are not getting. Versus a way of this way, where you reach out by looking at what resources are available at the house, by the village, what is appropriate, what you mentioned, appropriate technology at that level, which is sustainable, positive, blah, blah, blah. You're seeing this now more in various other ways also.
Related to that is maybe a question of if you think we scale up, that's the thing you create, that falls into different contexts. So maybe the solution that we have to think of is not the same for every of those contexts. So how then do you develop a system whereby the solution gets adapted every time? Every time you have to go with these complicated pilot projects,
Well, I don't think
that's the question.
it's not necessarily a complicated project. I mean, I think if your thinking is always, well, what are we going to do with this, you know, and so on and so on. Let me conclude, see if maybe this will answer it, with what I alluded to earlier, a proposal to look at HIV/AIDS. Now, I don't think you guys do AIDS work here, right? But you understand, you know enough about it, right? So let me contrast that with the TB situation. And also ask you to think about, is this model relevant to treating hypertension or diabetes? Because these are the things that you're going to see in some future thing. All right? So is that all right if I can move on to that? We've got another 20 minutes. So let's compare TB and HIV/AIDS. And the similarities, they're both infectious that require long-term therapy, Both have this stigmatizing component to it. Treatment reduces transmission of TB and to some degree HIV/AIDS. Non-compliance in both of these can lead to drug resistance. We're seeing drug resistance now in Africa, especially to the AIDS drugs. That's guaranteed that was going to happen. Difference is that HIV/AIDS is incurable, it's lifetime, and the percentage lost is oftentimes higher. So, the requirements for a bond for the treatment of HIV/AIDS, here's a modest proposal. That a monetary bond be required for service, not drugs. Those are free. They could still be received from fixed facilities. The bond would be kept in an interest-bearing account that would roll over every 4 to 6 months. The bond would be recovered only on death, on removal of treatment if reported in person, or on moving if reported in person. So the very things I talked about earlier. And treatment would be community-based for the most part, not facility-based. Going back to this issue, who are we doing this for? The doctors? Convenience or the patients? Convenience. So, the requirements is you would have to have a community-based system. You'd have to get the treatment by non-professionals, non-nurses. The community could contribute to the bond if necessary. Treatment would be combined with education. There would be a reliable health system that was staffed by doctors and nurses for complications. But most people on these drugs don't have complications. 80%. I'll make it for them. So we're worried about that 20%, but not the 100%. And you need excellent management and frequent supervision. What are the outcomes? Well, fewer patients would be lost to follow-up because the bond would be forfeited if you did any of those things. Compliance would increase. Deaths would be reported because the beneficiaries would collect the bond and any interest that accumulated. Treatment could be discontinued for any reason. Community-based treatment would identify problems earlier and reduce the work of the fixed facility. People may come to a facility because they have questions. You can answer the questions in the community. And education would play a very large role. Because people would know. They'd say, have you told your wife that you got this problem? So on and so forth. Objections. Neighbors will know who's receiving care for a stigmatizing disease. Do you think they don't know now? How come, Richard, you're going to the clinic once a week, and I saw you going into the AIDS treatment facility? Are these secrets? Do people not really know? Non-medical personnel will deliver the treatment. In some countries in the world, non-medical personnel cannot deliver medicines. It's against the law. Not so in India. Patients may not be able to afford the bond. You look at that. Community health workers may not be allowed to deliver drugs. I mentioned this. Same as the second one. And foreign donors who supply lots of the drugs for AIDS, may object, even if this is locally supported, as it doesn't meet their standards. The golden rule of development is not the golden rule of the Bible. The golden rule of the Bible says, do unto others as you would have them do unto you. Treat others the way you. The golden rule of development is whoever has the gold makes the rules. Okay? Advantages and disadvantages. Advantages is you ensure better compliance through incentives and disincentives. Incentives for worker performance, regular follow-up, continuous education. The disadvantages, long-term care with an unclear endpoint. What's the endpoint? The endpoint is infinity, until you die. That's the endpoint. Maybe from this disease, maybe from others. Drugs are delivered by non-professionals. And you've got to develop a payment scheme for the workers. And what about people who couldn't afford it? But in my view, what you should be looking at is this and not using this to limit what you do. Not focusing on the disadvantages, but looking at the advantages. Could the system work, and this is the final one, for non-infectious chronic diseases, such as hypertension? So, well, the bond could be delivered before therapy began, and interest on the money withdrawn on compliance. Patients could be paid for maintaining their health, blood sugar, blood pressure, and so on. Treatment output could be tied to insurance. These are all suggestions, all of which would have to be played with and tried. It might be applied for only the first 2 or 3 years of a program, and then somebody would get habituated to taking their drugs on a regular basis. Community-based management by non-professionals and follow-up would be required with periodic clinic visits. Now, the difference here, of course, is if you don't take your antihypertensives or you don't follow your diabetic, that's your problem. It's non-infectious. So one could argue there's less of an incentive for the system to treat these people and so to ensure compliance. The issue with TB, with HIV, with any infectious disease is that non-compliance puts all of us at risk. Non-compliance here does not put us at risk in the classic sense of the word. So, that's my modest proposal, which people could look at, and we go back to what I talked about. So, that's all I've got to say on this topic. Any other comments or questions? Yes, please.
I think with both of them, I see also certain advantages and disadvantages from, at least from our experience with the health services.
Yeah.
One is with a chronic disease which is non-infectious.
Right.
It would be easier for